Hello, everyone. I'm Barbara Hamlee. A heart, the universal sign of love, particularly in February when we celebrate Valentine's Day. But today, on Another View on Health, we're going to talk about your real heart and how to protect it from heart disease. Some of you may be thinking, haven't we heard all of this before? But we posit on today's show that you cannot hear it enough. The signs, the symptoms, the testing, the changes in lifestyle. We'll talk about it all with cardiologist and my co-host on Another View on Health, Dr. Keith Newby. Stay tuned. We'll be right back after this news from NPR.
Discussing today's topics from an African American perspective, this is Another View.
Hello, everyone, and welcome to Another View. I'm Barbara Hamlee. So glad you're joining us this afternoon. Want to say a very special thank you to those who came out last evening to the World Affairs Council event. We talked about African Americans in international affairs and had a great conversation with Ambassador Gina Abercrombie Winstanley and Dr. L.D. Britt, and it was a great conversation. So thank you so much for participating and joining us. So today's Another View on Health is very personal for me. About a month ago, as many of you know, my dad unfortunately became a part of the statistic that says 1 in every 4 people die of heart disease. Now, even though we've covered this topic before in the show, I truly believe that we cannot share enough about heart disease and the root causes that are so very prevalent in the African American community: hypertension, high cholesterol, smoking, and obesity, all things that lead to heart disease. I'm so happy to be able to talk about this with our resident cardiologist and co-host of AV on Health, Dr. Keith Newby with the Fort Norfolk Medical Cardiology Associates. Hey there, Keith.
How are you?
It's been a long time since we talked.
Yeah, too long. I thought you were ducking and dodging me or something.
I promise you, I have not been.
Well,
Absolutely.
I'm sorry for your loss recently.
Thank
I know
you.
that was always tough anytime you lose a parent. I don't care what the situation is. So my heart and prayers are always out to you, and I hope you're able to get through this in a way that you can get some peace.
Absolutely. And then, as I think about my dad, and my father was always about information and about understanding. And so that's why it was important for us today to do this show. And it is Heart Month also, as we talked about. But I was talking to my mother this morning, and I asked her about specifically what was listed on the death certificate in terms of Daddy's heart disease. And it said acute coronary syndrome. So tell us what that is and kind of how that plays into this whole idea of people dying of heart disease.
Well, essentially what people sometimes don't understand is when you talk about blockages in heart arteries. And I always use analogies when I'm teaching patients about heart disease. If you look at, say, like a car, and I use analogies that people can understand. Say you have a car and you have a fuel line going to a carburetor. Well, if that fuel line is wide open, then you can get in and drive, go at whatever speed you want to, no problems. But when you talk about, say, a partially clogged fuel line, you think about, say, I could maybe be able to drive 10, 20 miles an hour, and enough fuels get into the carburetor to make it run. But when you start increasing speed, that's when you start having trouble. If you surpass how much fuel can get to that carburetor, then you're just going to start to sputter. Well, the heart can do the same thing. What creates acute coronary syndrome is characteristically not that blockage or that partially blocked fuel line, but then you get clot on top of the blockage, and that is what causes that. So a lot of people will get transient either total occlusion of the vessel or just a spitter of blood that gets through. But the tissue that vessel is supplying is compromised, meaning it can't get adequate flow in order to function, and that can cause problems. Now, really what typically happens and what causes sudden death in most people is not the actual blockage itself, is what the blockage causes. And again, another analogy, I always use house as an analogy. In your house, you have your structure, you have your foundation, your ceilings, your walls, and you have doors and rooms in the house. Where if you look at your heart like that, the heart itself is like the house, and the chambers are like rooms, and the doors are like or at least the heart valves are like doors that separate room to room, chamber to chamber.
Okay.
In your house, you have electrical circuits and you have plumbing. And each, like the coronary arteries are like the plumbing, but you have electrical circuits that you need in order to make the house function as you will in your heart. Now, when you have compromised blood flow, it can compromise the electrical system. That's what typically causes sudden death. You get a sudden change in blood flow, and what that can do is it changes how the chemical reactions occur within each myocardial cell. That can lead to an electrical disarray. And then that leads to, you ever hear the term ventricular fibrillation or ventricular tachycardia. Those are essentially rhythms incompatible with life, meaning you cannot contain or maintain an adequate blood pressure with your heart racing off, or if not an aortic contraction, you can't generate enough pressure to keep your blood pressure up, and then it falls off and people will sometimes die. That can be a sudden onset as a result of acute coronary syndrome.
So, using my dad again as an example, now he had heart pains, chest pains, and went to a doctor, had what we call stress test. As I know people are very familiar with that, but blockages were not diagnosed at that point. What then is the stress test supposed to do? And then how do you know when you need to keep having more tests done in order to find out what's going on?
What I typically tell people all the time is medicine, and I always joke when I talk to my wife about this. I told her if I wasn't a doc, I probably would be an FBI agent or something, because I love detective stories, and I love all my favorite shows have been police detective shows. Medicine is like you're like a detective, so you have to look at all the clues, you have to look at all the findings, and some things may look one way, but it's a different way. If you look at most situations in medicine, and it tells you, one of the things as a Duke graduate, they always taught us how to analyze data, and you have to look at it in such. So you look at risk factors. Say example, I had somebody come to the office who was 18 years old. Who they say I was having chest pain, and you do a stress test on them, and the stress test is totally normal. Well, the likelihood of that person actually having coronary disease is pretty small. Now, every now and then you'll have a congenital disorder or something they were born with that may compromise blood flow, which is why oftentimes we may do a stress test in somebody young, because we're looking for the other things.
Tell people if they've never had a stress test too, what that test is exactly.
Okay, a stress test.
I've had one, so I guess that's why.
Not a problem. A stress test essentially it stresses the heart. What you're trying to do is you're grading, just like we talked about that carburetor situation. Usually when you're on a treadmill or you do some other form of exercise, your heart requires a certain amount of blood flow, because the blood flow, the heart is pumping blood to the rest of the body in order to do a certain amount of work. Well, the heart needs its own food supply in order to pump blood everywhere else, and that's how it gets it through the coronary arteries. So when you start like walking very slowly, you require a certain amount of flow, and as you increase speed, you require more flow. So all the stress tests typically is a graded treadmill test where you start off at a very low rate, usually it's like 1.2 miles an hour, and then every 3 minutes it increases in speed, and you have an EKG and a blood pressure cuff attached. And sometimes we use imaging tests along with it, so that we can figure out, make sure what the blood pressure is doing, what the heart rate is doing, any heart rhythm issues. And the whole point of that test is you take them up into different stages, and you want to see A, how well they can exercise, B, when they exercise, do they show any signs of compromised blood flow? And you can see that oftentimes with an EKG or sometimes in some imaging component. So when we talk about looking at these types of tests, what we're trying to figure out is, okay, does this person have blockage? Now, this is the issue, and this is why probably what happened with your father. A lot of times, the tests, what they're doing, because they're not perfect tests, and that's why you have to look at the rest of the picture. What I typically do when I'm evaluating somebody as a detective is I'm looking at what are the risk factors this person has. Usually I'm talking about somebody over 50, they're diabetic, they have high blood pressure, they smoke, they have high cholesterol. I know that person's going to be 8 times more likely than an 18-year-old having disease. So you say, okay, and there's a false positive rate probably, maybe somewhere between 5 and 15% where you will have somebody who has a negative test, but they actually, in fact, have blockages. What's happening is when you're looking at these tests, especially if you do an imaging component with it, and you ever hear the term nuclear stress test or stress echo, what we're looking for is is relative differences in blood flow, meaning you have three main vessels going to these different areas of the heart, and you're looking to see whether or not one area is getting better blood flow than another area, or one area is getting less blood flow than another area. And these tests are designed to tell you those differences in regional blood flow. Now, example, say a person has poor blood flow everywhere. Well, see, the test can't tell that there's a problem because as far as it sees, there's no difference in blood flow anywhere. So you could have blockages everywhere, but the test doesn't know that because there's no differences in blood flow.
All of it's still even.
All of it's evenly blocked. So the test may appear normal, but they have blockage, and that's where the doctor part comes in. We as physicians are supposed to, because what I listen for is the story. Does the story sound legitimate? You know, what did Cochran say if it don't
if the glove don't fit, it can't quit.
Well, let me be quiet on that one. I may get beat up on it, bringing up O.J. Simpson in here. But what you find, though, is you look at the story. You look at the risk factors. You say, okay, I have people with, say I have somebody who's over 50 who smokes and they have high blood pressure and they're diabetic. Well, again, I'm going to look at that scenario as more significant. And if the story is equally as good, like they say, well, Doc, I used to be able to walk 5 blocks with no problem. Now, if I walk a block, I'm starting to get this burning in my chest, and I get exhausted quickly. Oh, I'm gonna be on top of that. I don't care what their stress test showed.
Gotcha.
If I have other things involved, now what the stress test is helpful with is just another piece of data to get you to the end result. Because you don't want to do heart catheterizations on everybody, because again, it's a waste of resources and money because these tests aren't cheap.
Yeah, I'd say they're
so if you don't want to financially burden somebody and cath everybody, because if their story doesn't fit, you don't want to just do tests on people.
But does that also not go to the importance then on the patient side to be able to tell you everything that they're experiencing? I mean, do you find that people try to hold back some things, or they don't want to? They don't want to tell you that they're sweating profusely or they're doing various things.
Well, you know how folks are. I mean, the thing that as we as docs, what we have to do sometimes, we got to push the envelope. See, to me, I look at the differences between physicians is how much you really care. And I hate to say, I know that doesn't sound nice, but the bottom line is like you think about your work ethic. And, everybody has a little different work ethic. Some are a little bit better than others, some a little less than others. But you have to say, okay, what's my dedication? I guess I took my oath very seriously when I did that Hippocratic oath. Now, it says, you first do no harm, but you give your best, you do your, and you treat people as you would yourself. If you follow that premise, you're going to dig, and sometimes I really like, sometimes it's not, I don't necessarily always like when we have like multiple family members coming in the room when you're trying to interview them, because they may not necessarily say things, but the thing is, meaning the patient won't, but the wives would tell everything. I have found characteristically, every now and then it flips and it's the man actually doing all the talking and the wife won't say anything about what's going on with them, but characteristically, I have found that it's the wives that really tell the story. As an example, I won't say a name, but I have a patient recently, who his his description of what he was feeling didn't sound anything like his heart. I mean, absolutely nothing about his story sounded heart. It sounded like he was having a cervical disc problem. Like he was having, what he described, it didn't even remotely, and I dig, but it didn't sound anything like heart. So I really wasn't pushing the envelope with him heart-wise, even though he had a heart problem in the past. I was listening for him to tell me something that sounded heart. But he didn't, and then I said, well, let me, I went ahead and ran a stress test on him anyway because, I needed to do it. His stress test was positive. It wasn't remarkably positive, but it was positive. But when he came back in for the follow-through and I wanted to talk, because I usually do a face-to-face when we talk about doing heart catheterizations, the wife kicked in about what he was going through, and it sounded everything like heart. So I'm looking at the dude. I'm like, dude, what is it about your rendition of the English language is different from hers? Because what she's telling me sounds exactly what, that's telling me what I need to hear. Just did the heart catheterization on him yesterday. His left main is blocked. He needs open heart surgery, and he's going to have it soon. So, it's just, that's the kind of thing
So
that.
it really is important not only for the patient, the actual patient, to pay attention to the symptoms and so forth, but for family members and wives, husbands who are around that person to be able to really kind of hone in and remember what's going on.
It really helps
and
a lot.
share it.
Yeah, it really helps a lot when you hear that, because they will say things that other people will not say.
If you're just joining us, you're listening to Another View. I'm Barbara Ham Lee. Join us. Our phone numbers to join our conversation are 440-2665 or 1-800-940-2240. What questions do you have for us today? We're talking about heart and heart health. 440-2665 or 1-800-940-2240. We have a question from Facebook, and it says, is it true that muscle mass affects your heart?
Well, I'm assuming what they mean is muscle mass, like the just body mass.
Muscle.
Yeah.
Mm-hmm.
Yes and no. I mean, muscle mass, not so much. So fat mass, yeah. I mean, just keeping it real. Because what happens is not so much the muscle mass. Because usually, if you have high muscle mass, that means you're pretty active. Mm-hmm. And people with high activity levels are characteristically going to be in a better physical condition.
You have to exercise your heart.
Yeah,
too,
yeah.
right?
Essentially, that's what you're doing. I mean, that's why I tell people not so much the anaerobic stuff like weightlifting, what have you. I'm thinking more aerobic stuff. Mm-hmm. Biking, cycling, all that stuff trains the heart, and it actually makes the heart more efficient. That's why we advocate the exercise, because it does impact. Now, when you talk about, people say like marathon runners, you always hear the story about some dropping dead, they had heart problems, and you'll see that a lot. But just remember, those marathon runners, there could be other factors involved. They could have a very, very strong family history of heart problems. And even though they may be runners, do they see their doctor regular? All those things play a factor. That's that detector story.
Is heart disease hereditary?
Yes, it can be. Now, it's not always, because again, just living longer, that's why you see older people, having heart problems, because they're just living longer now than we used to. Just think about when your joints deteriorate, or, your heart can have similar things. You can start getting atherosclerotic plaque that develops just living, which has nothing to do with a family history. What dictates family history is premature heart disease. You talk about somebody like in his first degree relatives, not cousin Sally twice removed, but if you're a mother, father, brother, sister, who had some form of heart problems, age 55 or less, that indicates, because that's saying there's some genetic predisposition. If you're like 80 with some kind of heart attack or some heart event, that doesn't dictate or indicate a family history per se, at least not of premature disease.
All right, let's talk about some of the things, because there are some things we can do to make sure that, or to try to lessen the possibility for us to get heart disease. One is talk about the soul food thing and obesity. Yeah. Because weight is a real issue, correct?
The key thing is just how much. I mean, it's like anything. And I tell people all the time, I don't want people to ever feel like when they come to somebody like me or whomever that, our job is to make your life miserable. I mean, people that, they come in, they don't want to hear this, they don't want to hear that. And I tell them all the time, our job is not to make your life miserable. It's really supposed to be to enhance your life. We want you living happy, healthy. And I don't tell people you can't have it. The problem with especially our folks is we don't know how to stop. We don't know how to turn it off. We don't know how to say, okay, I'm only going to have this amount and then I'm going to back off. And I tell people all the time, I mean, I'm not perfect. I don't, my weight, I always call myself the Luther Vandross some medicine. I can go up and down on my weight, stress levels and things. I mean, we know living does that. We all know that. My job, as I say, is to encourage people and to try to educate them to say, okay, if you're doing this, these are your obstacles you may run into by doing this. And really, it's really not so much a beat-up session, but it's an encouraging session. Okay, if you're doing this, like say if you like certain foods, just don't have it every day. Maybe say, okay, I'm going to curtail the amount, and I'm going to reward myself. Okay, I'm going to do, like say, 2 weeks of being good. I'm gonna have this one day. I'm gonna eat something I want, and then go back the next day and do another 2 weeks or whatever you really want to do. But you just have to caution and understand, what you're doing and how you get in trouble doing it.
So is the whole idea behind if you're obese that is making your heart work harder? Is that?
Well, part of it is that, but the other part and more important part is what obesity causes. Obesity causes diabetes. It causes hypertension. It causes your cholesterol to be high. Everything is a cause and effect, and I know sometimes patients will beat me up because they keep saying I'm harping on the weight issue, but I'm telling them, I said, but that is the trigger that's causing all this other stuff to occur. So, if you get rid of one thing, then it's a chain reaction. Everything else will get better. Your blood pressures will come down. It's well documented in the literature. Your diabetes will get better, well documented in the literature, meaning that there are studies showing people can reverse a lot of this. The problem is people won't stick to the game plan. They start off good.
So when I can come to you and I can say, and you say, Barbara, you've got high cholesterol and I'm going to give you this pill.
Yeah.
Then I can go do whatever I want because I can just take the pill, right?
Well, that's what people think. That's why folks show up in that emergency room with no heart attacks. But trust me, I tell people all the time, it's a lifestyle change. It really is. It's you changing you.
But the pill is not going to just eradicate everything.
No,
and that's what I want you to talk about.
I'll tell you what happened when I was in medical school many moons ago, feels like now. That's when this issue of the fish oil stuff came out. And I'll tell you what prompted that was, and I remember this, some things you just vividly remember. I remember in physiology class, we went through cardiac physiology. Actually, I think it was endocrinology. There was a study that was done looking at the incidence of heart disease in the Eskimo population, and they said that, and some brainiac came up with this conclusion that the reason why they had less incidence of heart disease is because their diet was consisted of a bunch of fish, which came up with omega-3 fatty acids, and that led to all this stuff that we're doing now. Now the problem is, and I tell people all the time, but think about it. The Eskimo population, number one, look at where they live. Look at what they do every day. I guarantee you there's a lot of physical activity. I guarantee you there's no smog, there's no stress like what we have here in the States because of how we live. Mm-hmm. There's, they don't have 7-Elevens around the corner where they can get, food. They don't have McDonald's around. They don't have Wendy's, all these other places where you get all this other stuff that may not necessarily be the healthiest for you. They don't have access to all that stuff, all the processed foods we eat. So, it's more than just that. It's the lifestyle itself, but that's where all that came from, was that study way back when, I'm talking about the incidence of heart disease in that population. Mm-hmm. So so the issue is that the weight, the stress, the lifestyle we lead, it's high intensity. It's always on the go. I mean, even I look at myself. I mean, I work all the time, and I know I need to change that at some point in time. I'm gonna have to. But when you work all the time like that, it does increase the stress level, and increasing stress level can lead to other things.
440-2665 or 1-800-940-2240 are the numbers to call. Give us a call and let us know, what are you doing to change your habits so that you can be more heart healthy? 440-2665 or 1-800-940-2240. So this question goes kind of along with what you were just talking about from Facebook. This person says, I've been reading that the vitamin supplement cosamine 10 or CoQ10 can help with your overall heart health. What are your thoughts on that?
Well, again, it goes back to the lifestyle issue. It can impact, because that's what they call it. It's supposed to eradicate oxygen-free radicals. Oxygen-free radicals are supposed to kind of stimulate damage inside the vessel, which can lead to, because what happens is on the intimal layer, the inside layer of the vessels, if that becomes damaged, that is almost like the body says, they look at that as an injury, and so it tries to heal that injury, and that's when scabs and stuff, like if you think about it, you cut yourself, where on the outside is open to the air, so there's nowhere for, it's nothing. It's not like an enclosed tube like your artery. Right. So when you have an injury inside the vessel, the body sees it as an injury. It says, okay, I need to heal it. So it starts to try to stimulate growth and things to try to heal that area. Mm-hmm. The problem is then the clotting factors get stimulated and all that. The CoQ10, all that's supposed to be designed to reduce the oxygen-free radicals in the body that will subsequently cause that. But it's more than just that. I mean, it can help, yes, but not by itself. It has to be that along with other things
that are going on. If you're just joining us, we're talking with Dr. Keith, cardiologist Dr. Keith Newby. He's also my co-host on Another View on Health, and we're talking about preventing heart disease. So let's talk about the stents and the things you do to open up a blockage, and how does that once that blockage is open, does it stay open? Tell us a little bit about what happens in that?
Essentially, it goes back to that comment about when you take a balloon and you go inside a vessel and you open that balloon, what you're doing is you're essentially cracking this plaque. Because that stuff is hard. It's like there's soft plaque and there's harder plaque. But most of the time, when you put a balloon across and you inflate that balloon, it's almost you think about like
like a drill going through?
Well, to some degree, but look at it even like a water hose. If you have a water hose, say if you had a water hose that's brand new, and you look at it, it looks brand new. I said, and it's viable, it's friable, you can bend it and all that. Right. But think if you let it sit outside for about a year, and then you come do
cracked.
It, a little cracked, and it's going to be stiffer and all that. Well, see, when you talk about opening those vessels, it's almost like you're trying to crack that thing that's been sitting out there for a long time, that water hose. So when you crack that plaque, that stimulates injury, and the body sees that as injury, and that's when it tries to clot it off, because that's what it's supposed to do. That's what you as your body is designed to do, is to heal things. Mm-hmm. Now, the stents are designed to keep that vessel open, but things still, all the blood clot mechanisms are right in there, so it can clot off, which is why we put people on blood thinners, because we do that to try to prevent platelets from clumping together, and we try to de-stimulate the clotting mechanisms of the body so that clot does not form. And that's why we put people on those blood thinners afterwards, or those antiplatelet drugs, and that's why we harp so much about them and try to tell patients who try to blow that stuff out like they don't need it. I'm like, you will clot that stent off if you don't take this stuff. And we usually talk about somewhere between 6 months to a year after stents are placed, we'll keep people on blood thinners. And it's designed to try to make sure that area heals well and all those clotting mechanisms go away. Mm-hmm. And then you can subsequently take people off those. Now, there are a couple of camps. Some people advocate leaving people on them forever. Some people advocate a year, and then they'll switch them back to just regular, just aspirin. Normally we do dual platelets, so we'll hit aspirin and something.
That's very
else.
Interesting what you just said. So some people have this form of way of doing things, right, and others have a different way. So when you're searching for a doctor, and is it more about being comfortable and the relationship with that physician, as opposed to the style in which they may choose?
I think it's a combination of both. I think you want to have somebody you can communicate with, because I think it's important that you feel engaged. And I think what patients tell me is, and that's a shame to say I take advantage of this, but I always love taking advantage of other people's bad habits. But it's when a doc doesn't talk to the patient, if they feel like, if the patient doesn't feel you as a physician are engaged in their care, they will get frustrated and leave you, because they don't feel like you really care about them. And it's not hard. I mean, intrinsically, that's my nature. That's one thing my mom instilled in me as a young boy growing up, was you caring about other people. And that's part of this, between my father being a physician and how he lived. Mm-hmm. You tend to gauge it. You get a certain something about yourself that creates you as to who you are. I've always cared about other people's well-being. I can't help it. It's just part of me. So I like listening. So that's been something that's been to my advantage, because and it's not hard being a doc. It really is not. I mean, you have to have some intelligence. don't misunderstand, but it's not. It's really more being able to listen. My older brother, one of the things we always joke on who, I always tell him he's way older than me. But anyway, but one of the things when he came into practice, and I was a medical student, and I used to hang out with him, because I was one of those gun-ho people that never wanted to take vacation. Anyway, I was learning medicine. I was in the thick of things. I wanted to learn stuff. But one of the things he taught me, and I never forget this, he says 90% of the time, the patient will tell you what's wrong with them. You just have to listen. And I've never forgotten that, and I have incorporated that in my practice style, because they don't know what's wrong with them, but they can tell you what they're feeling and what they're experiencing. And you, as a physician, have the medical knowledge to put it together and to come up with the conclusion of what's wrong with them based on what you hear. But if you're like, they always say that you go in the doctor's office and the doc's backing up the room time he walks in, you're not listening. You can't be. So if you're not listening, you're not hearing anything.
So speaking of knowing the difference, then a question is, how do you tell the difference between heartburn and heart disease?
That's going to be again that's that detective story thing. You look
Okay.
at the description of how they experienced it. If somebody tells me that they've been dealing with, say, like oh man, I've been having this hurt in my chest for a week and it hasn't let up in it at all. And it started after I ate some. I went to Taco Joe's and I had 20 tacos because I bet somebody I couldn't eat this stuff. And I mean, that's one thing. Because if you listen to how it occurred, it happened, after they ate something, which doesn't make it not hard.
Mm-hmm.
But the thing they said was it was constant for 7 days. Ain't nobody having a heart attack for 7 days straight.
Gotcha.
So you have to take the story and then you have to surmise what you hear and then you make a conclusion based on that description. That's why I say it's so important to listen, because you want to ask certain questions, but you let them do the talking.
So once you get heart disease, some sort of heart disease, can you eradicate it? Can it go away?
Well, you can improve upon it. You will always be labeled, unfortunately, so to some degree, but it depends on what it is. Say, heart disease is such a broad term, and if you let's define heart disease. Heart disease is defined as anything that affects the heart or the great vessels. So you talk about the heart, the aorta, all the arteries that go to like the GI system, the legs. If you have a blockage in your leg, that's considered heart disease. Your heart can look fine, but because it's the heart and the vessels are connected together, so it's one can affect the other. So anything that affects the heart or any of the vessels in the body is considered by definition heart disease. So I tell people all the time when they say, "Do I have heart disease?" I got to go through this list of stuff with them. I say, "Yeah, you do. Heart may be fine in general, but the bottom line is the heart is connected to those vessels, which subsequently has a problem in it." So by definition, you do. And even, they say if you're diabetic, people label you as having heart disease regardless of if you don't have anything, because we know the incidence of diabetics and heart disease is so high. If you look at the data that's done in the literature, it almost defines to say that people who are diabetic have the same risk of having a heart attack as somebody who's already had a heart attack in the past. And we know those are the highest rates of heart attacks are those who we know have had a heart attack in the past. So if you're diabetic, we just assume you have heart problems and treat accordingly. That's why we're so aggressive with diabetics.
440-2665 or 1-800-940-2240. Renee joins us from Newport News. Hi, Renee. You're on the air.
Hi. I would like to ask the doctor, what do TIAs have to do with heart disease? My mother has that, and also Raynaud's disease. Okay. It's RAYNAUDS. What do they have to do with heart attacks or heart disease?
Well, just it chimes in on my comment I was just making earlier. Is anything that affects the heart or the great vessels, and a TIA is an acronym for a transient ischemic attack. So that's where you have inadequate blood flow going to the brain, and that when they say transient, meaning it usually resolves within 24 hours. So it's not a stroke, because a stroke would define a permanent damage situation. I mean, you can of course get better from that, but the TIA is transient, meaning it only lasted for less than 24 hours, went away. But because it's connected to the heart via the vessels, that's why it's considered heart disease. So when you have diabetics, high blood pressure, high cholesterol, smokers, all those people are going to be high risk for TIAs, because, again, those are the risk factors that can lead to heart problems because of how it affects the vessels. Okay. Raynaud's is that's usually a vascular problem, but that's usually comes by via another mechanism. Raynaud's is characteristically something you'll see in things like lupus and like the rheumatologic problems, because there's a connective tissue disorder, and the vessels are connective tissue. So if you get inflammation and it causes vasospasm, and Raynaud's is when, especially in the distal and the fingers and the digits, they will clamp down, and you'll see changes of how the distal fingers look, because they're not getting adequate blood flow for various reasons. But typically that's a rheumatologic problem.
Thank you so much, Renee, for the call. We appreciate that. So the symptoms for men who were experiencing a heart attack and women are different, same?
It's variable, but what has been my characteristic experience, when we were growing, when I was in medical school, when I was, again, a long time ago, the premise then was that women, it's like when we were young, men and women had a vastly different profile as heart disease, meaning women didn't get heart disease till later in life. Earlier it was men. And then when you get into like the 70 plus age range, and all of a sudden women caught up with men. But we found that that's not the case. Women have it's almost the same. In certain situations, it almost could be higher, but it's not. Still men are still characteristically have a higher incidence of heart disease, but women are far behind. Mm-hmm. Part of that is just because I think change in how we are now versus how we were 30 years ago. Obesity rates, diabetic rates, all this stuff has increased. Plus, now we identify things better now than we did then. With some of the testing we have now, we can identify the presence of heart disease. We can identify people who are at high risk, and we subsequently are able to catch things earlier. Symptom-wise, I will say that women characteristically do not have the textbook presentation that you'll see for people with heart disease. I've had women say, I just have back pain, and that's it. There's no shortness of breath. There's no anything. I've had some people just say jaw pain.
Okay, so if you take that, I just have back pain. At that point, it might be too late.
No, not necessarily. Again, look at it's all that detective story again. Look at it as, you have
even
to.
before I come see you, if I think all I've got is back pain.
Yeah, now that's true. That's why sometimes you see the sudden death rates or the death at home rates are high, because people will ignore some of those things, or they'll write some of it just gas, and as you know, they die at home because they just blew it off. But the way I always tell people is this: I say, listen, look at yourself in terms of what is it that is about you that's different from everybody else. If you know you have high blood pressure, you're diabetic, and then on top of that, what's worse, if you're trifling, you don't take anything, you duck and dodge medicine like it's the IRS or something. Then your likelihood of having a problem is going to be greater than the standard normal population. If you smoke, you're overweight, you do all, you have all these risk factors, then you need to be more careful than anybody else. So if you experience something, don't ignore it. Just get it checked out. Because you don't have to run to the emergency room every time. But, if you're experiencing something, that's not right. I tell people all the time when they call at night, I'm having this, should I go to the emergency room? And I'm like, well, most of the time, the answer is no, because, probably if you look at 100 people who come in with chest pain, only about, the incidence I remember reading is 12% of people that go to the emergency room actually have a heart issue going on at the time. Mm-hmm. But the thing is, you don't know who's in that 12. So I tell people all the time, if you will feel more, I don't think it's an issue that you need to run to the emergency room, but if you're going to feel more comfortable going, I'd rather you go. Mm-hmm. And just get checked out so you know that you're okay. And then we can always pick it back up in the office.
I know you and I have had many conversations about the whole idea of health insurance and what's going on in the country and so forth. And the fact that if you don't have insurance or you have inadequate insurance, that could also keep you from going to check out that symptom.
Yeah, I tell people all the time when they're looking and evaluating, people always want to go for, they don't really look at what they're getting in that plan. They just go for the lowest, premium they can pay. And I said, just remember, you remember what you're asking for. You're getting what you're paying for. I said, you need to evaluate each plan and in its entirety. As an example, if I have hypertension, diabetes, high cholesterol, I have GI problems, and I have bad arthritis, and I have, say, rheumatoid arthritis. Well, in my mind, I know the likelihood is that I'm going to need a lot of medicine, probably. Mm-hmm. So you want to pick a plan that has a better drug coverage, for that reason, because I realize what my needs are going to be versus a 17-year-old kid who exercises every day, has no health issues whatsoever. Then you talk about, I can understand that person getting a plan that has a very, very low premium, because the likelihood of that kid having some major issues is going to be pretty small. Right. But when you start getting into, at least my age range, I won't talk about your age range, my age range is a little higher. I realize that, I know I have to be more careful with that. So I got to start looking at, okay, what's going on with me? My staff in my office always jokes on me because I have probably the lowest blood pressure. It surprises me sometimes with the level of stress I'm on. I would think my pressure should be a lot higher, but typical pressure is 104, and that's about the highest I've ever seen.
Really?
Yeah. I mean,
man.
I don't know how. I mean, I'm
really
just blessed.
chilled. That's what it is.
Just trust me. They know I get stressed out now, but it just doesn't. I've just been blessed. I mean, my pressure's never high.
Well, speaking of high blood pressure, so if you are on medication, and I'm asking this because, and I'll use myself as an example, have lost weight, continue to lose some weight, the blood pressure has leveled off, everything's going great. Am I still going to have to stay on these pills for the rest of my life?
Well, see, the thing is, this is my feeling about that, and I know I've had that's all a issue of practice style. My personal opinion is that I believe in that punishment reward system. But the thing is, if somebody doesn't need you, the question at first is, why'd you put them on this mess? You put them on it because you saw a need for something that was going on. Now the question becomes is, if that need all of a sudden goes away, do you still need to have them on it anymore? And typically the answer is going to be no. Certain situations may be different, but most situations when you talk about the chronic illnesses, high blood pressure, diabetes, high cholesterol, I'm not going to keep a person. Rarely would I keep a person on a cholesterol medicine if their cholesterol is 100.
So because I guess there's a continuum, I would imagine, then, in terms of how long, if your cholesterol has stayed at 100 for a couple months, a year, 2 years, I don't know what that time frame is.
There's no real right or wrong answer to that. What you have to look at is the entire picture. The only time I would favor keeping somebody on a cholesterol level or medicine, despite what their levels may be if they're diabetic. Say they're diabetic and they're you ever hear the term A1C level?
Yes.
Hemoglobin A1C is a kind of a marker, a measure of how well controlled your diabetes is. Typically, you're looking for levels. You'd like to see them, less than 6. If you're greater than that, then you're pre-diabetic. And say if you're greater, they keep changing the number now. I think if you're over 6.5 now, they consider you as diabetic. It used to be 7. One time it was 7.5, and that number keeps dropping. Yeah. So and I understand why they're doing that. It's all about outcomes. So if you say if you're a diabetic and you're very, very well controlled, and you say your A1C level's 5.8 or 5.7 or less, then I'm gonna look at that person different than I would versus their A1C is 11 and their cholesterol might be 100, but I still know that person's risk is relatively high, and I'm gonna do everything I can to mitigate that risk. So the one thing, that's why I tell people all the time, medicine is not like other things where there's like a formula, you follow this formula and hence this is going to go well. I mean, medicine is so dynamic, it's so fluid, it changes all the time. There's no two people, like your profile, my profile, Lisa's profile, everybody may be different.
I've been in groups where people start comparing the names of the blood pressure medicines they're on. And so, well, you taking this, are you taking that? Why are you taking this? I mean, you can't, because you are diagnosed one way and someone else would be diagnosed differently, correct?
Yeah, I had me, I'm very bluntly honest. When I had somebody the other day, he said to me, and when they come at you hard, you come back at them hard. He said to me, Doc, I was at something and somebody I was here, they were on this pill and that was the only pill that they were on, and their pressure was fine. You got me on 3 pills. What's up with that? I looked at him, I said, because you fat as crap, and you ain't lost 1 pound since I've known you. You haven't followed one instruction that I've ever given you. You do what you want to do, and that's why your pressure's high, and that's why you need all that medicine. I bet you money that other person don't look like you.
And people still come to see you.
They do, because they know people know I'm going to tell them what they need to hear, but at the same time, they know I care about them. That's why I say what I say, regardless of anything else. People know I care about them. So I'm not going to say anything. I'm not going to blow you smoke. I'm not going to tell you something. Now, I've had some people that won't respond. And the beauty of medicine is you got to know who you can say that kind of stuff to. This guy and I, we've known each other for years. So, I mean, we have that kind of relationship. I may not say that to everybody. I may say a little different to somebody else. That particular guy, we've been together for 20 years. So, I mean, we talk smack to each other all the time. So that's partly what our relationship. But the thing is, you have to know how to say certain things to certain people in a certain way, because you may respond one way somebody else may respond a different way. So I have to adjust how I present information to you is going to be different from how I say it to somebody else.
So if you have a patient then who is a true advocate for themselves, they've done their research, they've done some homework and so forth, do you appreciate that?
Yeah,
And does that help you in terms of the patient-doctor relationship working together, or is that more intimidating?
No, well, nothing about this stuff is ever intimidating to me. I feel very comfortable in my knowledge base, what I know, how I look at the world. I don't feel intimidated by anybody saying they've done X amount of research, because I guarantee I know the data better than they do. And I encourage it because they need to know what they need to know. The problem becomes is when you don't know. Sometimes you have, like, the internet is a great tool, but at the same time it has things you got to know how to interpret that information. The problem is if you read something and it's not accurate. I mean, everything on the internet is not accurate, and that's hard to convince people of that. That you have to be careful with your interpretation of what somebody says, because I can put anything up there I want to.
Yeah, that's
Don't
true.
make it right, but I can put it up there, and people will take that and they'll run with it. The problem becomes they don't take that time to really analyze and say, okay, let me look at the source. How worthy is that source? It's just like a vitamin pill. I had somebody say, I got this vitamin pill. Should I take it? It says it's going to do this and do that for me. And I say, well, where'd you get the information from? And they'll show me some little pamphlet with some study that that was done that says greatest thing next to sliced bread. So I just look at it, I read through it, and I say, oh, the company that's selling this drug is the one that did the study, right? And they said, well, yeah. I said, well, ain't it in their best interest to say it's the best thing next to sliced bread? I said, you can't use this. They're going to say it because they're trying to sell you something. I said, you got to look at independent data, randomized trials that look at a question. I said, then that's how you get your answers. This people, they just trying to sell you this stuff. I mean, you could think they're going to tell you that drugs the worst thing in the world.
We've got about a minute left. I want to ask a question. Should you always bring another person with you if you're facing a serious conversation with you about a heart issue?
I think always,
or
yes.
Anyway.
Only because your mind is going to be somewhere else. I mean, you want to hear this, but when you think about it, if somebody tells you something that's going to get your it's going to worry you or going to have you think, can you be focused enough to hear everything that's being said? Sometimes having another person in the room will help you, that you'll be like the backup to that person, so that anything that you miss because you're worried about what you're hearing, that person can pick it up as well. So I always advocate that.
So we always encourage people to give us a call and let us know what health issues they would like to cover. I think next month we're going to be talking about Parkinson's disease, which some folks reached out to us and said that they'd love to hear more about that. So thank you so much, Keith. I appreciate it.
I always enjoy the conversation.
Explaining some things to us. Absolutely. And we will be right back.
I'm Robert Battle, Artistic Director of the Alvin Ailey American Dance Theater. You're listening to Another View on 89.5 WHRV-FM. We're so looking forward to being with you this weekend. We hope you'll come out and see the Alvin Ailey American Dance Theater in audience favorites, in new works, in Revelations, Alvin Ailey's masterpiece that he created in 1960, one of the most seen and celebrated dances all over the world. It's the suite of spirituals that expresses the experiences of African Americans in this country. You don't want to miss this company. 31 of the most magnificent dancers you could ever imagine. So we look forward to you joining us.
And I am looking so forward to that this evening, actually, going to go see the Alvin Ailey dancers. That is fantastic. It's been 140 years since Norfolk's Hunton YMCA opened its doors. Throughout its existence, the facility has been a safe gathering place for children to learn and play, and adults of all ages to gain instruction, hold civic meetings, and worship. Our Lisa Godley looks at a few of the many lives the historic Y has impacted since it all began more than a century ago.
Growing up in Young Terrace, Shonda Crocker saw things a child shouldn't have to.
There's a lot of violence that go on, gun violence, killing. I know people that's in jail for murder.
She knew there was a Y just a few minutes away, but family members were busy and thought it too dangerous for her to walk there alone. But when Shonda turned 16, that's exactly where she went. She got a job working with the children as a recreational aide and over time worked her way up to supervisor. She saw the importance of the children having a place to go, and the Hunton YMCA was it. At the same time, the Y was also helping shape Shonda, who had set her sights not only on finishing high school, but college.
A lot of my friends didn't go to school or finish school. I'm 1 out of 10 that finished school. Most of my friends haven't even finished high school. So I just graduated in December. So I'm like an oddball in my community.
Shonda Crocker is just one of the many lives Norfolk's 141-year-old Hunton YMCA has touched. Named after William A. Hunton, the first full-time paid director of an African-American YMCA, the Hunton Y has helped fill a void in the communities it serves. Development and Community Engagement Consultant Denise Good explains.
Norfolk State had some of their first classes at the Hunton YMCA. Churches that didn't have a charter or a name held their services there. So it really was a community place.
Christina Moore has worked at the Hunton Y 16 years. She says it's a staple that many parents rely on, providing homework assistance, meals and snacks, educational enhancement programs, and summer camps. But that's certainly not all.
The staff sometimes provide things for the children like socks and gloves. Sometimes we'll go out and buy shoes for the child if we notice that the child's shoes are too small or something like that.
Remember how Shonda Crocker's family feared for her safety so they wouldn't let her walk to the Y as a child? Christina Moore says safety is still a concern, but they deal with it.
The parents depend on us to keep their children safe. They know if they're within the building, they know that we treat all of our children just like they're our own. But once they walk out of the door, then they have no covering until they get home. And a lot of the children have to walk through those areas in order to get home, and they're faced with the gangs. Sometimes we literally have to walk them to their front door.
It's that genuine concern and nurturing support that keeps generations of families coming back to the Hunton YMCA.
We had a parent who loved us so much. She and her husband, because he was in the military, moved to Texas. She called us every month just to check on us to see how we were doing and telling us that she missed the YMCA and her children are not being cared for the way that they were at our Y. And even in Texas, she still sent people to us to take care of their children so that they can enroll in our Learning Academy program and be a part of our community recreation program. The minute that she moved back to the state of Virginia, she came to us the very same day and filled out her application just so that her children can come back.
The Hunton Y will celebrate more than a century of service to the Norfolk community this weekend with a fundraiser where they'll feature another Hunton Y success story, LeVar Stoney. Stoney was the first in his family to finish college and the first African American and the youngest at the age of 34 to hold the position of Secretary of the Commonwealth. For Another View, I'm Lisa Godley.
And I have the pleasure of serving as the MC for the event tomorrow afternoon, celebrating the Hunton YMCA. It will be at the Slover Library from 3 until 5 p.m. Tomorrow afternoon, there will be performances and remembrances and a great opportunity to speak about the Hunton and what it has done to make such a difference in the lives of people here in Hampton Roads. So we hope you will join us for that. I also want to encourage you to please go to our website. We have several events on our website that you may be interested in attending, including the Proudly Diverse Caucus is hosting a Norfolk City Council and Mayoral Candidates Forum on Saturday, March the 5th at Lake Taylor Middle School. That's from 10:30 until 2:30 in the afternoon. So you may want to check that out also. Thanks so much for joining us today. We shared some critical information about heart disease that you may want to share with others. So go to our website, anotherviewradio.org, and download the podcast. You can also find us on Facebook. I'm on Twitter at Barbara Ham Lee, and you can watch us do radio on YouTube. Just look for the WHRO channel and then Another View. Our theme music was composed and performed by Jay Sennett. Lisa Godley is our show producer, and Victor Bowen is our audio engineer. I'm Barbara Ham-Lee. Thanks so much for joining us, and we'll get together again next Friday at noon for another view.